Northwest Territories. Oh, Rebecca, welcome. That's amazing. All right, I'll stop greeting everybody and let's get to the heart of the matter here, everybody. Thank you so much for taking time out of your day to join us for our next connected conversation. So, not until you lose weight, why obesity is a barrier for arthritis and joint pain treatment, and should it be? Let's have that conversation today with our amazing guest, Dr. Harman Chowdhury, that I will introduce in just a moment. But let's just set the stage for a second for anybody who may or may not have joined Connected Conversations in the past. We are super proud of these ongoing series that we're offering everybody. We're bringing these to you from Obesity Canada. And in these conversations, we really try and dig into the important topics for those of us living with obesity and chatting with experts in the field. From advocating to access for evidence-based treatment, issues related to diet culture, weight bias, and discrimination, to innovating obesity care in Canada, we really want to try and take these complex issues and break them into smaller conversations so that we can really empower those of us living with obesity or those of us supporting people living with obesity. If you haven't met me before, my name is Lisa Schaefer, and I am one of the hosts of Connected Conversations. I'm a patient advocate. I am a member of the Connected community, and I am someone with lived experience that has been navigating life with obesity my whole life, let's be honest. Professionally, I'm a marketer out here in the West Coast, and for the last 5 years, it's really been my honor to serve and volunteer here at Obesity Canada and really try and challenge the conversations, change the conversations, and work arm in arm with Dr. Ian Patton, who is also here joining me in Connected Conversations.
Yeah, thanks. Thanks for that, Lisa. And hi, everyone. Welcome, and thanks for joining us today. Like Lisa said, my name is Ian Patton. I'm the Director of Advocacy and Public Engagement for Obesity Canada. I've been with the organization as a student. I started as a student and trainee about more than a decade ago, and I've stuck around as a volunteer, and now I work with the organization. So this is something I'm definitely passionate about. Like Lisa, I have my own lived experience that I share openly, and I advocate for access to care and the reduction of weight bias and discrimination. So this is definitely something that I'm passionate about, and I'm always eager to have these conversations and dig into these discussions that our community has actually let us know that these are the important topics that they want to hear about. So I'm excited about today's, because this kind of starts chipping away at a really big topic that we get a lot of comments and questions and complaints about. So I'm eager to have this conversation, and I'm sure it's going to lead into a number of other conversations around this type of topics. So thanks for joining us, and I guess a little bit of housekeeping for today's webinar. Like always, we have our chat feature, so you can join the conversation, put your thoughts and comments into the chat. If you have any questions for us while this is going on, you can throw them into the Q&A feature, which is in the menu at the bottom there, and we'll monitor those and pull in questions as we can during the conversation. If you see questions there that you like, you can upvote them and things like that, so that you don't have to repeat the same question over again. If someone else had a similar question, you can just upvote it, and then it'll pop it up to the top, and we'll be able to see it a little bit easier. And then other than that, I think I'll let Lisa get rolling with this.
Love it. Pitter patter, let's get at her. Not until you lose weight, why obesity is a barrier for arthritis and joint pain treatment, and should it be? So joining us today is Dr. Harman Chowdhury. He is an orthopedic surgeon in the Sunnybrook Holland Orthopedic and Arthritic Center in Toronto, Ontario. His clinical practice is focused exclusively on hip and knee reconstructive surgery. He obtained his medical degree and surgical training from McMaster University, during which time he completed 2 years of intensive research in clinical trials and the analysis of big data in healthcare, which is so interesting to me, and I might need to have a side conversation with you about that, sir. He completed his surgical fellowship at Western University in adult hip and knee reconstruction. Dr. Chowdhury has a special interest in complex and revision, i.e. do-over, hip and knee operations. Welcome, Dr. Chowdhury. Yay.
Great. Thank you. Thank you very much for that introduction. It's a pleasure to be with you here this afternoon.
This is fantastic. And as Ian said before, I think he and I are both very interested in this conversation because it is a topic that comes up in our community a lot. Individuals living with obesity, we're turned away from care or treatment because we need to improve our quality of life strictly based on what people look at and see our BMI. I recently bought a t-shirt that says the BMI is trash. I'm obsessed with it and I want everyone to wear one. But some procedures have these arbitrary weight loss prerequisites, and other people are just denied care altogether and sent home with no plan or advice other than just go lose weight, which we know actually weight is not a behavior. That is not something that we can really just tell somebody to go and do. So while this is not something that's terribly unique to orthopedic treatment, I think it's an area where we hear a lot from our community members. So I think that's why we're really interested in chatting to you and hearing from your side of the fence, kind of what this is looking like. So before we get into all the ins and outs of that, if you could maybe tell us a little bit about yourself, your role as an orthopedic surgeon, kind of what led you to this interest in this topic about obesity or as a barrier. And yeah, just tell us the story of you, Dr. Chowdhury.
Absolutely. No, I think you've told a lot about my educational training, which I won't recap. I'm a hip and knee surgeon. Like that's my passion. That's what I was trained to do. And that's what I love to do, as we discussed just before this. And so I want to be clear, I'm not an obesity expert by training. Rather, my interest in this area has been fostered by clinical experience, and specifically, I'd say the negative experiences of many of my patients living with obesity. When it comes to accessing care for arthritis and joint pain. So a little background, I was recruited to Sunnybrook Hospital at the Holland program probably around 2018. The Holland Center in downtown Toronto, we're a regional center. Most of our patients come from outside of Toronto for a variety of reasons. And in my own practice, I noted two recurring themes. The first was wait list. So patients, this is another huge topic, right? Patients been told to wait, over a year for surgery. So we get a lot of people coming in from out of Toronto, out of Ontario often, looking for shorter wait lists. And, because of our model here, which is, again, that's a different topic, we are able to offer surgery much quicker than that. So a lot of my patients came for weight issues. But the other, I would say the biggest issue I would see in my own practice was patients who had been denied care by another surgeon because of their weight, as you mentioned. And by denied, I mean a variety of things. So some were, told, go lose weight, go lose, 50 or some unreasonable amount, right? Go lose 50 pounds and come back to me. And then we can talk about surgery. Some people were told, I don't do this surgery, this type of surgery is not offered to people at your weight level. And then in the worst cases, people were actually blamed that they had done this to themselves. And, it was the recurrence of that story. And it was like so many people, I can't even enumerate how many people I've seen like this, sitting in, literally in tears in my office, going over this. And just hearing that I'm able to offer them a surgical procedure without, losing 100 pounds. Just the joy of that and all the traumatic experiences that went through in their minds as they had this conversation. It's what kind of led me to think about, why is this happening? What are the barriers to access? And, is there like an opportunity to improve care in the area of people living with obesity? So, it's really been my own experiences and the negative experiences of my patients that have led me to this topic. And, at some point I connected with Ian and he offered the opportunity to talk to you guys. So yeah, we can go over a lot of that. There was a lot there. So that's kind of the starting point.
No, and that's fantastic. And, again, I'm on a conspiracy of kindness and looking for all the hope in the world. And I love that you are another embodiment of this next generation of care that we can hope we are creating in this world too, that is willing to slow down and have the conversations and really kind of look at individualized care as well. But let's keep going and talk about this joint pain world that we know so many of us are in pain actively looking for support. So as an orthopedic surgeon, you deal with a lot of hip and knee issues for patients who come to see you. For someone with limited mobility due to joint pain in these areas, can you kind of help us understand or briefly explain like what effective treatment might look like from your perspective and how that really does impact quality of life? Because at the end of the day, that I think that's another point that Ian and I really like to focus on is, it's not about numbers and your weight. It's about quality of life and health.
Yeah, exactly. So I'll talk to you a little bit about, care for joint pain. So when I'm talking about joint pain, I'm talking about like wear and tear joint pain over time, which is also known as kind of arthritic joint pain or wear and tear joint pain. Certainly if you have joint pain because you've twisted your knee or you've had a fall, like that needs to be addressed, if there's a specific injury, whether that needs to be addressed with a cast or physio or a specific treatment, like that would be a discussion you have with your doctor. But like when it comes to this chronic pain that you get in your knees or hips and, even shoulders and back, how do you treat that? So I would say it depends on how bad the pain is, how bad your function is, and of course, how severe the pathology is, or, on the x-rays or the MRI, what it shows. So we typically start off with the least invasive measures and then progress through the continuum of care, right? So first we try to optimize the muscles around the joint, improve your balance. Formal physical therapy is part of that. But, with physio, it only really works if you do it consistently. So for me, I rather, the two things that I found people really benefit from are either cycling, if it's, for your hips and knees, it's getting on a stationary bicycle or a normal bicycle. And the other thing is swimming or aquafit. Like those two things, when I recommend those, it seems people come back better. Walking is neutral to me. Like it's not bad or good. It's something you should do for your health, but I don't think it'll improve your joint pain necessarily. And then, stretching is good. So like yoga type activities or something where you're increasing the mobility of your joint, that will over the long term help your joint pain. After that, then you're looking at symptom control. So that's where you get into your medications, Tylenol, Advil, Aleve, topical creams, using a sleeve or a brace and so forth. Later after that, then you're looking at injections. So things that can be injected into your joint, whether that's a steroid, a lubricant, some type of platelet or stem cell type thing, which is more experimental. And finally, then surgery is where I come in. That's the most severe cases. And usually surgery is like you're looking at either a joint replacement if it's very bad, where we actually replace the knee or the hip or shoulder or whatever, whatever we can. But there are some other options as well, whether that involves realigning your leg if it's too angled. That's an option. There's partial joint replacements. And then there's also minimally invasive things you can do. But again, that's not really for arthritis. That's more for kind of injuries. So anyway, so in a nutshell, that's it, right? So you start off with the least invasive. And by the time people get to me, I'm happy to discuss that with patients. But usually, by the time I see people, it's like I said, it's a third or fourth opinion. Like we just get on with it and do the surgery. And again, so people tend to be happy with that as well.
Mm-hmm. It feels like it's what they've been waiting for probably this whole time too, to be able to get.
Yeah, exactly. Like they've seen like 3 people, or even if they haven't, like with the wait list, by the time I see people, they've been waiting for years sometimes. So anyways, so yeah.
Definitely challenging. So as people living with obesity, we're often told that our excess weight and the weight we carry is a risk to our joints, especially our knees and hips, pardon me. Can you talk a little bit about the relationship between that excess weight and obesity and some of the issues that you kind of run into on a regular basis? And kind of like, is obesity management or discussion about weight part of your joint pain conversations? But maybe let's start at the beginning there and talk about like what you see on a regular basis, some of those grievances that you've heard.
Yeah. So, okay, the wear and tear. So, why do people get joint pain? Like there's 2 components. There's like anything, right? There's a genetic component where, your people are predisposed, right? You hear about these people who tell you about their, my grandmother had a hip replacement. My mother had a hip replacement. Now I'm also having one, right? So, there certainly is a predisposition. Now, increased load through your joints will increase how quickly they wear out, whether that's because of muscle, whether that's because of fat, adipose tissue, or whether that's because, your job, you've just carried heavy things throughout your life, right? So anytime you've increased the load through your joints, you're going to wear them out quicker. So patients living with obesity, I tend to see them, to be honest, a little bit earlier. So I would say probably in like their 40s or 50s, rather than like 60s to 70s. But that's the same for like heavy laborers or, you know, anybody who's put increased load through their joints. You know, I think weight reduction is part of management, you know, but it's a bit controversial, right? Like, because the amount of weight you would have to lose to improve, you know, A, your surgical risk, and B, your symptoms is often, you know, it's astronomical, and often to the point where, like, if you can't walk, you know, it's very difficult to lose that amount of weight, right?
Yeah.
So it's something that I do bring up, and if the patient is genuinely interested, and because the first time they're hearing about it, you know, I talk about it, I offer resources, and again, I'm not an expert, but you know, if somebody's, you know, tried to lose weight, or you know, they've gone through everything, you know, I really, you know, we talk about it, and they said, you know, if they're not interested, it's not something I necessarily dwell on. So that's my approach, and everyone's approach is a little different. You know, so, you know, I think it is part of management, but you know, a lot of things are part of management, like, you know, stop, you know, lifting, you know, heavy concrete bags, you know, and I do tell people that too, right? Like, and you can't, some people can't do that because that's how they make their living. So, you know, everyone's unique. And I think, you know, it's something we talk about, but it's not something we, you know, necessarily dwell on.
Nice. I like that a lot. And just even the sentiment that everyone is unique, because that is kind of the heart of all of this as well. Just because you might see my chart and not have met me or spoken to me, my numbers might tell you one thing, but in speaking to me, you might understand that I actually do lift weight, or all of those kinds of things, those moments, right? I see Ian came off mute and he's a kinesiologist, so I'm going to let him talk for a second.
No, it's just, wow. Yeah, it was just something that I remember hearing, and I can't remember whether it was through my schooling with kinesiology or if it was more something I heard in the fitness industry, like in a gym or something. But I'd heard it multiple times about the excess weight that people carry, and it was something about, like, for every pound you carry above your knees, it's like puts 5 times that amount of pressure on the knees and the hips, the joints below that weight. So it was kind of like making a point about that, and I wasn't sure how true that is. I know that there, you know, obviously it does put a little bit of more wear and tear, but I don't know if it's to that degree.
No, I hear you. I mean, I think I know exactly what diagram you're talking about. Like, there's like this like force diagram show, you know, kind of, you know, going upstairs or something. And I agree. I mean, that's physics, right? But there is other aspects to why people get pain. Like, it's not all because of, you know, there is other aspects to pain, right? There's soft tissue pain. There's, you know, how much can your muscles compensate for that pain, and all other things as well. So weight is a significant part of the pathology, but it's not, you know, the only part of it, right? So I agree. I mean, it's not all just physics, right? And we know that, like, even in surgery, we you know, there's things we do, and then you do research and you find out, you know, even though theoretically this is the case, like, it's not necessarily it doesn't make a difference necessarily, right? So anyways.
Fascinating.
Yeah.
Did you see any questions you want to insert at this point, Ian, or are we?
Well, there's a couple that we could jump to quickly. There was one actually when we were talking about the exercises and stuff that you recommend to people. So you talked about like swimming and stationary. Someone asked about rowing, whether that would be something that would be a positive compared to some of the other ones. But
gotcha. Yeah, I mean, again, so this is just stuff, again, like, I don't want to be like, this is not like science, right? Like, it is science too, but like, it's a lot of this is just my clinical experience. And, you know, those two activities seem to be, you know, the things that I see improve people's pain. So, you know, rowing is like, so if it's, you get it, you know, it's typically like non-weight bearing activities that are like cyclical. So that's where the cycling comes in, right? So rowing to some extent is kind of like that, right? Like, I don't know if they're talking about a rowing machine or like actually rowing, like, you know, actually rowing, but I assume it's very similar. And again, you know, I think anything that you're doing that's kind of low resistance weight and it's cyclical, like, you're building the muscles that stabilize your joints, like, that's going to help your joints. I think rowing would be, you know, I've done a little bit of rowing. Like, I think it is a very beneficial activity. I just don't have a huge number of patients that do that activity that I can comment that, you know, that necessarily is definitively helpful. But I think if you find it's helpful, it's definitely worth pursuing.
That, and Exactly. If it's helpful and you enjoy it.
Exactly.
Also, go with that. I found an amazing place here in Vancouver that does like group row classes that are kind of like group spin classes, and it gets super intense in there and it's super fun.
Yeah.
So yeah, I mean,
Yeah, it's got to be
again,
consistent, right? Like it's
yeah.
got to be, that's my problem with like, I hate writing, physio, because I know what's going to happen. Like, 90% of the time you'll go to the physiotherapist, you're going to go there once, maybe twice, three times, and then it's not going to be, you don't enjoy it. So you're not going to do it. It's got to have a context, maybe a social part to it, like a group part to it. It's got to be something you do consistently.
Yeah. It's not the same. And I bless the physiotherapists out there who tell us to all work out with our soup cans at home, but we're creatures that are human nonetheless and are going to do what we're going to do, right?
Yeah.
All right, let's talk a little bit about that moment that you mentioned is a little bit controversial, which I think is adorable because it's quite controversial in this group, about that weight really being a barrier to treatment. So we know many of our community members have stories of being denied care for a number of conditions based on our weight. Surgeries to treat hip and knee joint pain are some of the more common ones that we do tend to hear about. The denial of treatment generally falls into two categories, and I think we've kind of touched on these too. The patients are either told that their elevated BMI puts them at an elevated risk for complications during surgery, or we're told that the patient has been told that without losing weight, there's no point in repairing that joint because our extra weight will just equal more wear and tear.
Gotcha.
Is that something that you've seen in practice? And what is the evidence used to support those kinds of decisions, since you have your evidence-based book behind you, my friend?
Yes. Yeah, no, that's a great question. Okay, so the evidence is clear that, in my world of, arthritis surgery, if you don't have a complication, and you're living with obesity, if you don't have a complication, your functional outcome is about, is going to be the same, right? And in my experience, maybe even better than any other patient. So the key really is to make sure you don't have a complication. If everything heals up, you don't have anything that, nothing breaks, you don't have an infection, in the long term, your outcome is going to be just as good as anybody else. So the key really is, how do we avoid complications? Are the complications higher in patients living with obesity? And I would say yes. I mean, the research evidence would say that you do have a higher risk of specifically infection. Infection is higher after about a BMI. Like, I know the BMI is not a perfect measure, but about a BMI of 40, your infection risk goes up, probably about double. And then after about a BMI of 60, it goes to probably about 5 to 10 times higher. Okay, so bear with me here. Like some of the math, the average risk of infection after a hip or knee replacement is 0.5%, right? So even if you're 5 times higher than that, you're only at about 2.5%, at most 5%, right? So that's still horrible. Like, if you get a deep infection, it's a big deal. That's
awful,
right?
Yes.
But I don't think it's a statistic that we can reasonably use to deny someone surgery outright, right? It's something that it's a risk benefit discussion. And like I said, if we can get you through that period and manage that risk appropriately, your outcome, you can expect an outcome that's as good as anybody else's.
And
so,
what would be
ahead.
the things that the patient would be able to do to help mitigate that infection risk? What does that look like?
Yeah, I mean, it's hard to, we don't really know why, people, so everyone's different, right? So some people are, like I said, BMI, for example, is a very crude measure, right? So if you have a BMI of 40, but you also have other risks of infection, like diabetes, and
Gotcha.
maybe you smoke, and so forth, right? All that stuff adds up, right? So you got to optimize everything else. You got to make sure your nutrition is good. You got to make sure that you're healthy, you're not smoking, that kind of thing, and do, in general, doing the best you can. You got to make sure, from the surgical perspective, you should make sure that the surgeon that you choose, or the facility that you choose, is used to treating people with higher risks of infection. For people living with obesity, like, they have that experience, because there are some things we can do as surgeons to mitigate that risk as well.
Nice.
And then in the end, just gotta, after you have your treatment, you just, keep a close eye, ask your surgeon or your doctor, what should I watch for? What should I monitor for? Just so if something does happen, you get on top of it as quick as possible.
Yeah. Right? And I love that, because that's all about the things that Ian and I often talk about in the crowds as well, talking about like, just control your controllables and help people understand what they can control and what they can't control. To your point, absolutely. Can I be healthy? Can I be taking my supplements? Can I be eating properly? Can I stay hydrated? Can I make sure that I'm walking around so I don't get blood clots? Like all of those moments. And I know from interacting with this community and being an active member of it, like we're all here. We want to participate in our health and our wellness. It is all we want to do, quite honestly. So meeting someone like yourself across the table who can paint that realistic picture that absolutely there's risk. I don't want anybody to be naive and think that surgery doesn't have any risk, but like that fear of that greater risk and that perpetuating this myth that we're already behind the 8 ball when we even walk out the door. That's the part that I think we want to try and help people navigate.
And the other thing I just want to mention is like, so again, I'm a surgeon, but I'm affiliated with the university and I do quite a bit of research. There's no evidence that telling someone to lose weight actually decreases their risk of surgery. The only thing that's ever been shown to decrease risks after a hip or knee replacement is actually getting like a gastric sleeve or some kind of bariatric surgery. That's been shown to decrease risks, but actually trying to lose weight, like, because you have to lose like 100 pounds with a very stiff joint when you can't even walk, like that's never been shown to work. So that's why I don't tell people to necessarily go lose weight. Like it doesn't work, right? So, and we know it doesn't work. So that's not something that it's not a conversation that you need to be really focusing on, because there's no evidence behind it, right? So again, and again, even with gastric surgery, some people, the wait times and stuff, like, they can't wait that long. Like they can't have a surgery before they have another surgery.
Yeah.
Right. So these are just things that, to keep in mind. And I think it comes back down to, just advocacy, self-advocacy, unfortunately, but yeah.
For sure.
Yeah,
Ian?
we'll see if my mic is working a bit better.
Project to the back of the room. Yep.
People were saying that my mic wasn't working. So the point there about self-advocacy is something that I think I wanted to jump in here, because I think you made a really good point there that I wanted to reiterate about the numbers. So you said that, people with elevated BMIs have, a double risk, double the amount of risk, 2 times the amount of risk for infection. And then as it gets into higher BMIs, it's even higher than that, which sounds scary, right? If I'm thinking about it and that's the only, language I'm using, double the amount of risk is scary. And that would be a cause for concern. But then when you put it into actual numbers and talked about the actual percentages, like it's significant compared to people with lower BMIs. But relatively speaking, like if you're talking to a patient, a risk, a 2% risk of getting an infection versus the change in my quality of life that I'm, potentially going to get with this treatment, the cost benefit, like the negative versus the positives there, is drastic, right? Like it's pretty big. So I think that's important, and something that as patients, if we understand that a little bit better, maybe being able to ask questions or push back on that a little bit, rather than just saying, oh, they double the risk and they're not going to do surgery, I've got to, move on. So that self-advocacy part of it, I think, is important. I'm wondering if you have, as the doctor on the other side of that conversation, do you have any advice or thoughts on how people could broach that topic with a doctor?
Sure.
Yeah.
Yeah, no, I want 2 parts to that. So first of all, I don't think that I, as an orthopedic surgeon, should be making this decision alone, right? Like this is not like, the era of paternalistic medicine where the doctor tells you what to do. And there are some patients who are still like that. They want the doctor to tell them what to do. Like, I think that era is over. Like, this is a mutual decision, and we got to talk about risk tolerance, right? So somebody who can't sleep or even stand, you will likely accept more risks than somebody who just gets pain when they're golfing, right? Like the golfer might just say, I'm not going to golf anymore, right? I don't want double the risk so I can golf. Whereas somebody who can't even sleep and it's been like 6 months is going to accept double the risk, right? So you're right. Like, there's different types of patients and how bad their symptoms are. And that's why the risk discussion is so important. And I guess the second part of your question was just about in terms of how to advocate, right? In an ideal world, I don't think, you should have to advocate, right? Like, this should just be like, okay, like this is a complex case, like perhaps this is how we're going to deal with it, right? But, unfortunately, the reality of today is, you have to kind of figure out how to advocate for yourself. I think just asking questions, asking for a second opinion, talking to your, friends or somebody else who's had a good, experience. And I think I mentioned to you the first time we spoke, like there should, I don't know if Obesity Canada is I think it is the right organization, that perhaps there should be some type of guideline or resource where these are the facilities or physicians or practitioners, physiotherapists that specialize in patients like, living with obesity. And, these are individuals you can contact, right? So, unfortunately, and I've seen it in my own practice, like people who speak up, people who advocate for themselves and their family members, like they end up, they overcome the barriers to care. And unfortunately, people who don't have the resources or the means to do that, they have a little bit of a harder time. So,
and that is such a big part of what Ian and I often are speaking to people about as well, because we tend to be a cohort of people that haven't shown up for ourselves or feel like, or maybe that I know for myself, I shouldn't speak for everyone. It can often feel like when I go into those moments, I've been waiting to get this appointment for a really long time. So when I'm in the room, I don't want to do anything to mess it up and feel like now this is going to get yoinked from me, which can often be the way it feels. And that happens with weight loss surgery. I imagine that happens in your office as well, right? So it's all about how can we get to these real conversations that we need people to be having and helping them understand, be honest and look for an ally in this doctor or surgeon that you're sitting across from. And maybe I won't get my surgery in the next month, but if I have somebody who's invested in this with me and we can make a plan together, that should feel really good for people. And that's, I think, the world we're trying to build towards. And it sounds like the way that you operate already, sir. So thank you.
Yeah. And I think it's important to understand, like, there's things that make surgery complex, and certainly, obesity does make surgery more complex. And sometimes, the person you're talking to, despite, being referred to that physician, that's not their expertise. And sometimes they themselves don't know that, there's someone's more specialized or somebody who has an interest in this, kind of thing. So, their gut response is like, can't be done. I can't do it. Probably nobody's going to do it. Like, who am I going to, find that can do this?
Yeah.
So, that's why I think it is important, whether there's some kind of database or something patients can use to, define, like, obesity, people interested in obesity, these, practitioners, whether they're physicians or physios or chiropractors or, some kind of resource, right? Because that's a starting point. And, eventually, hopefully, like I said, that'll become antiquated. We won't need that anymore at some point in the future. But it feels like right now we need it.
Yes.
Yeah, we do have we have our clinic locator tool, which we're hoping to expand. So right now it does, on the website, the Obesity Canada website, it does have, if you're looking for obesity management, so they have like obesity specialists and clinics that specialize in obesity management, people who've taken extra education and training in obesity management. So that's in there. But the hope is that we can expand it to, like you just said, have those other health professionals, other doctors and areas of specialization where they are recognized as, being resources, being good resources for people living with obesity, and even getting into like allied health professionals that specialize or work with people living with obesity. So that's something that we are hoping to work on and expand. But
and then we have our connected community as well, which is, I think could go one of two ways, but I like the idea of our community really sharing with each other their experiences, like positive, negative, like what they've found to work. And I love the idea of empowering people to go in a room with a little bit of a checklist or a bit of a script if it's new to them, to even, it can be very intimidating. Dr. Chowdhury, you're a doctor. You're supposed to know everything. For me to sit across the table from you and really kind of poke a little bit and ask questions can feel really intimidating. So I think if we can empower people and have this kind of script kind of idea when they walk in the room to be able to go, how can we have a risk benefit conversation? And how do you feel, doctor, whomever, about the risk benefit of this? So you can really understand their perspective, because it's still valid to have that perspective.
And I think, like nowadays, like, people are, I get a lot of questions. Like, people ask me like, how many surgeries have you done? Like,
Wow.
Are you comfortable doing this? Right. There's, and people, and, I think, there's two types of people, and, some people are still a little bit, like myself. Yeah. I'm kind of like, like I even as a physician, like I'm a little bit timid, to ask these questions, but people are very forthcoming. And when I get those questions, I answer them. And I think similarly, you can ask your physician, like, I know you're saying like, that I'm at a high risk and I can't have this operation, but, is there somebody else that you can refer me to? Is there, are you not comfortable in this situation? Like something like that, right? You can, anyways, you can, that's all about, that's all advocacy is about, right? So
totally.
Sometimes it's easier for someone else to advocate. Some of the most effective advocates is like, if you take a friend with you, right?
Yes.
So, if you're uncomfortable, take your friend with you and, get them to advocate for you, because it'll be far less intimidating for them to do it rather than you. So
yeah, and I mean, I'm always talking to people, or I work with people and I help them advocate for themselves when they need information, so we provide them with evidence and stuff like that. And the one thing that I've said, and I was pretty comfortable doing this myself, and being able to tell a doctor, like, you're obligated to run an evidence-based practice, and what you're telling me to do right now is not evidence-based. I have no problem doing that, because I live in this world and I can, I have the evidence and information that I can back it up. There's a lot of people who, maybe don't have a PhD in obesity research and, maybe aren't sure that that's appropriate. Or the other part of it is that, they're wanting, whether it's going for orthopedic surgery and they want to get care and they've been waiting for a long time, and they feel like this is like the end of the line. And if they make this doctor angry, or they're not gonna, doesn't work out with this, or they push back too hard, they're not going to get the surgery at all, or they're not going to get any treatment at all, and then they're left with no other options. So there's that kind of balance of, when is it appropriate to push back a little bit, or to advocate a bit. And there's times when I've told people, start with the light gloves and try and be nice about it and friendly, but then there's times where you kind of got to push back, because you deserve better. You deserve better treatment. But then that little bit of concern about whether that's going to eliminate them from getting the treatment or starting all over again at the beginning, that's a limiting factor as well. So I'm not sure if there's any way around that, but that's definitely something we hear about.
It's all about that building your care team too. And again, trying to find the right people, which again can feel like a bit of a luxury from time and resource perspective.
It does. It almost feels like it's, not to mitigate it or anything, but it's almost like when I'm trying to find like an electrician and I don't know who to call. It's really like somebody I know that like, hey, try this guy or this, woman. So, and I find a lot of my patients, like they're just word of mouth. Like I don't advertise or anything. Like I don't, have a website. It's just kind of like, you operated on this friend and you said, and anyway, so that's how most people seem to get referred to me and my colleagues by word of mouth. And that's why I think, if you just, talk to some of your colleagues, I think you'll find a lot of information. Again, I this is just practical advice. I don't think this is how it should be. And I do think we should work towards creating a system where, this is not an issue, right? So
100%. And that's what Ian and I do all the time. We're doing bottom up, top down, right? So I want my cohort of people to be able to go and show up. And then I absolutely want to stump and create better systems for people, because we need things that are going to be sustainable too.
For sure.
So I'm just going to flip back. And I think we might have touched on this briefly, but I'd like to just dial in on it before we move to the next section. But when it comes to that hip and knee pain for arthritis, how do you determine if the risk of treatment is greater than the potential impact on doing the surgery? Or what does that moment look like for you as you're making those assessments a little bit?
Yeah, no, I think basically exactly what I had said about like just having a discussion with the patient. Like I actually tell every patient I see, regardless of who they are, I say, I don't live your life. So you need to tell me how only you know how bad this is, right?
Yeah.
And so I'm like, I can offer you this. These are the risks. I just lay them on the table, right? And some people say, no, sign me up. I've thought about this for like 1,000 years. And then, some people say, like, I give them my number and I say, go home, think about it, and give us a call. And, ultimately, like I said, I don't make that decision. They make that decision. So
powerful. That unto itself feels really powerful too. I love it.
I like I said, this is something that comes across our desk from our community members quite often. And so there was one recently that I was working with a little bit, and this woman had quite the harrowing experience that had been years in the making. So she is someone who's living with obesity. She had some other obesity related comorbidities. The assessment and the imaging that she got for the pain that she was having determined that she was in need of knee replacements. She needed surgery on her knees, and she had gone through and saw a surgeon who she had seen previously for something different. And I guess through the experience, she was denied treatment. So she was told that because of her BMI, she wasn't going to be able to get surgery. She asked for a second opinion, got a second opinion from the same clinic. And that was an even worse experience, where she experienced some pretty dramatic weight bias right there in the office, obviously making her feel pretty terrible. And it just didn't go well. But essentially what it came down to was they said that she would have to lose weight before she was going to be able to get the surgery. Initially, she was told that it was because she was higher risk. When she kind of pushed back on that, it was because she was a higher weight and higher BMI, that the surgery wouldn't be very helpful if they did it, because she was still higher weight afterwards, and she would, it wouldn't be good for the knee joint after they did the surgery. So it was kind of just this counterproductive conversation where, she's being shamed and blamed in the office by healthcare professionals for something that is, a chronic disease, and being denied quality, treatment for something that could improve quality of life and allow her to live the active lifestyle that she wanted to, that would hopefully help with other things. But essentially just being told, no, there's nothing we can do for you. You're on your own, go away. When they were telling her that the surgery was too risky, or she was at a higher risk because of BMI, the next sentence was, have you considered bariatric surgery? And so it's like you're saying one surgery is too risky, but another surgery is not, make up your mind, which one's which, right? And so from a patient's perspective, these can be they're very hurtful. They're demoralizing, but it's also very confusing, right? Like we just don't know, what our options are and stuff. So luckily this woman did get a second opinion at a different place, and she ended up getting the surgery, which hopefully went well. But those are the experiences that we get, that come through our community quite regularly. And so I was wondering, from your perspective, what should that kind of clinical experience look like for the patient, or how should that have gone? And what should that approach be? What could patients do to maybe?
No, I think that's a very powerful example and an excellent question. And I think, the elephant, well, not really the elephant in the room, but it is the, is the weight bias, right? Like, does it exist in healthcare? And I think we know it does, right? Like there's no denying that we, as a healthcare system, we need to do better, both individually, but also as a system, right? So, there is some evidence, interestingly, that patients that have medical issues like obesity tend to wait longer for surgery than completely healthy individuals without obesity in the Canadian system, right? So that even right there, that's a systemic bias. Like that's not an individual practitioner. The entire system is biased. You can see that. And it's because of this phenomenon of what we call cherry picking, where more complex patients are pushed down the wait list, and patients that are less complex are moved up. And there's various reasons for that. They're not all malicious. Sometimes it's because, you need a more complex bed, like a hospital bed, a specific set of resources that are more readily available for, people without obesity rather than people with obesity. But there is there is certainly, a bias there, right? So I think it's important to be aware of that. And I'm sure, because of your organization, you're spreading that information. And, once you know that, I think you can view the system through that lens and know that, sometimes when you hear things, you don't necessarily take it at face value. And like I said, perhaps some advocacy is in order. How should that have gone for that patient? I think, like I said, this is complex surgery. This is not surgery that you want done by somebody who does like 10 or 20 a year. Like you want to go to people who, the institutions that do hundreds or thousands of these procedures. And, perhaps one of the things to keep in mind when, somebody says, you're too heavy for this, is perhaps they're not comfortable, doing your procedure. And perhaps that's a red flag right there for yourself. And I agree, it's with the wait lists and everything, it is challenging, right? But, like that's where the second opinion, I think, comes in, and I hear it sounds like the second opinion didn't go so well either. So, it's a complex situation, right? I think, the best thing to happen, like the ideal situation is you're referred, your family physician has a set of resources, they know exactly who to send you to. If they send you to somebody who's not comfortable, they then forward you to the appropriate person. Like that would be the ideal situation. And, the system right now is not perfectly set up that way. Like I said, it's important to advocate, ask and insist on a second opinion, talk to your friends, talk to Obesity Canada, use Google, send me an email, do whatever you need to do. But I think, finding the right person to take care of you is the most important. And I think everyone deserves to be treated with dignity and respect, regardless of, the situation. So if you get the sense that you're not being treated, I think it's quite valid for you to call the practitioner out on that. Like, just, say, I don't feel like I'm being treated with the appropriate dignity and respect right now. So,
and I've even had other people say, or they've pushed back on the doctor and say, is that something you would say to someone with a normal BMI? Mm-hmm. Right. And like that can be a bit of a shock, like, oh yeah, maybe I need to look at this a little bit differently. There's a question that popped up here, and I think it kind of ties into this because we were talking about the different complications and stuff. And I forgot to mention this one because it's something that I've heard as well about other risks. So you mentioned infection, but the other one that I've heard actually quite regularly is when it comes to surgery, the anesthesia. So for people living with obesity, there's a higher risk with anesthesia. And so that's why people have been turned away from various treatments, not just orthopedics, but other treatments and things like that, because there's a higher risk with that. Is that something that is true?
I would say, depending on, so again, it's all varies, right? So BMI, like up to like 40 to, even like 45, like, it's probably fine. It's very similar. Again, I'm not an anesthesiologist. I have had patients that, for example, they would say we need an ICU bed just so we can monitor them more intensely after the operation. It is more complex. It's certainly more, again, there's higher risks. I've never had somebody who just, could not have surgery, because of the anesthesia issue. I've had people who said, like, you need a special bed. So, that might take a little longer to get that bed. So instead of waiting, 3 months, they're waiting like 9 months or whatever. Because it just, especially with COVID, like a lot of these specialized beds were in short supply. Mm-hmm. But I've never had somebody who they've said, like, you can't, because if you're in a car accident and you break your, femur, like, it doesn't matter what your BMI is, like, they'll give you anesthesia, they need to fix it, right? So it is riskier. And I think the same thing, right? It's a risk benefit discussion, mm-hmm. right? So if you're willing to accept the risks of anesthesia, then, then you've accepted the risks. Like we are capable of doing it. Yeah. Right.
I enjoy
and like
that.
You said, right? Like the bariatric surgery, right? Like how can you deny someone one surgery and then tell them to go get another one, right? So
and around we go. Do we have more from the community, Ian, that we want to?
Yeah, we have a couple here. There was someone who is, and I guess this is kind of relevant. They were saying that they needed knee replacement surgeries, and she was told to come back after she lost weight. She lost a bunch of weight, and then was told that that wasn't enough. And the doctor had actually said that you can stitch muscle and skin, but can't stitch fat. So they asked, is it possible to lose enough weight that the loose skin would then be a barrier? She had lost over 70 pounds, and that was something that came up.
Yeah. So I mean, there's an element of truth there. Like you can't stitch fat. You're right. Like it's like you pass your stitch and it'll just rip out. Like so, the only things you stitch together is the muscle and the skin, and the fat in between, the adipose tissue. It just kind of it just kind of stays there, and over time it kind of connects. So I agree. I mean, that's why that infection risk is higher. Like that's probably the reason, right? Because of the healing. So sorry, what was the question? Like, will the excess skin?
She said, like, yeah, I guess if she was told that she had to lose weight.
Yeah.
She lost a bunch of weight, was told that she still needs to lose more. So she was wondering if there's a point where losing too much weight and she gets that loose skin, if that loose skin would be a barrier.
Yeah, I mean, I don't know. Like my thoughts on this is like that, that person probably could have just had surgery in that moment.
Yeah.
I don't like, again, so I mean, excess skin, like I don't think that would pose an excess risk. No, I don't. Not compared to the baseline risk that was there already. But again, like it's hard to lose, even in the absence of joint pain, like to lose the amount of weight that you would need to lose weight around your knee, right? Is like you said, 70 pounds is quite impressive. Like I'm actually impressed that she was able to do that. But yeah, I mean, it sounds like this was more of kind of the practitioner just not wanting to do it at that weight level. And
yeah, and I mean, I don't want to put you on the spot with your colleagues or anything like that, and make it seem like they're doing something that's wrong. But I think, at least from the experience that I've had and the conversations I've had with people, it seems like these BMI as a barrier or weight as a barrier for a lot of these treatments, and not just orthopedic stuff, the other ones that we talk about as well. The BMI barrier seems to be more in place as a kind of like a filter out tool, where these are not ones we want to deal with right now in a lot of cases. And it could be for a variety of reasons. And we don't know, like each individual person, there might be a higher risk for certain reasons, and they might not be a good candidate for surgery. It doesn't mean everyone's candidate for surgery, but it just seems like a lot of these stories we hear are just doctors trying to filter out some cases that maybe they don't want to. It's almost like weight bias. Like they don't want to deal with these patients at this time.
Yeah, and it's a slippery slope, right? Because so in the United Kingdom, there are places, I don't know if it's still the case, but I'm pretty sure there are places that have a strict BMI cutoff, like above 35, you can't have surgery. Like my average patient BMI is about 35, I think. So, that's crazy. Like that is wild. So that's why, it's so important that we have that organizations such as Obesity Canada, because you don't want to end up in a place like that, where you have like these strict cutoffs and, so anyways.
Yeah, they can't be arbitrary like that.
It's very familiar to me. I've heard this story many times that you
disappointing. Yeah. There's one other question point that I'm kind of interested in just getting Dr. Chowdhury to weigh in for just a second. And that does have to do with the members of our community that live with lymphedema or lymphedema as well. And I know that that's another layer of complication in all of these moments, but it's a fair question to ask. So, what about those patients that are presenting with those issues as well, who despite efforts to lose weight are still going to have these mobility issues? Have you encountered that, and how have you been able to navigate, or any thoughts?
Yeah, it's not that common. During my training, I was told that lymphedema is probably like the highest risk of infection complication. Like some of these patients would end up with amputations. Like you just couldn't get the skin to heal. In my practice, I've operated on one person with lymphedema, and she actually did really well. But she, that was just and what we say n of one. That was just an example. One person.
Yeah,
It's a tough issue. Honestly, it is.
yes, it
These are
really
all
is.
complex challenges, and that's where it comes down to like finding a person or a physician practitioner, somebody who will sit down and it can't be a 5-minute appointment. Like this is something you got to go back and forth. Maybe it'll be multiple appointments. Like you got to talk about. You really got to figure out the risks and benefits, and hopefully that's all it is. Like hopefully it's just a risk discussion and everything goes well. But I agree. Like lymphedema is a very challenging problem, and it does add a significant risk of infection to the point where you could end up with an amputation, like at the end, right? And there are people who say like, I'm so bad, like cut off my leg. And once you say that, like I call that the amputation test. Like, at that point, like doesn't matter, like what issues are, like I have to do something, right? Because if you want your leg cut off, like you're pretty desperate. So, But anyways, it's another element of risk. I think you just have to have a discussion with your physician and come to a decision.
And I think that's like kind of the big takeaway from all of this is that, again, we all deserve individualized care and attention. And that's a big part of this, is really finding that care team that can work with you, working with the physicians that you're sitting across as well. And it can be really challenging. We grow up believing you're going to have the answers. I'm going to sit in front of you and your answer is final answer. Right. And it's nice to see this next generation of care that looks like it's evolving a bit and welcoming these kinds of conversations for sure.
Yeah.
So I think we're almost at time too. Sorry, did you have something that you wanted to?
No, I'm just like looking through the chat, and then just recently, I'm curious, like hopefully can I get access to some of this chat after? Because I haven't had time to read it.
100%.
There seems to be a lot of comments. Anyway, somebody said, like, does higher BMI make it too difficult to operate? I would say yes, like it does. And that's why, that's the reluctance you're facing from other people. Like it's very specialized work. And that's, like I said, that's why it's important to find an institution that is very familiar. And unfortunately, most of those institutions are in bigger cities. The more remote you get in Canada, it's harder to find good care. No, it's good. It's easy. It's not hard to find good care. It's hard to find specialized care. So it's important to go to somebody who has a lot of experience. And we've done the research here that shows that surgeons that operate on patients with obesity a lot have better outcomes than patients who operate sporadically on patients living with obesity. So again, that's just, it's one of those things you got to be aware of.
Yeah, for sure. But again, I love all of this because it's about creating conversation and really showing up for yourself as the person seeking this care as well, and trying to empower all of you guys to be able to have the right conversations. I think you had a very salient point too. And we were talking earlier about, some of those indications that a doctor may be hesitant are indications that they aren't the right person to do the surgery for you as well. And that can feel new to us because we're not used to being able to interview people like this in that moment. But I think that's really important and really telling. And we absolutely will export these questions, continue the conversation over in our connected community. But one that I do want to make sure that you hear is that everybody's a bit smitten with you, my friend. You're such a breath of fresh air. So, and you're a stellar example of what healthcare professionals should be, was one of the comments. So thank you for your time today. Thank you for what you're doing out into the universe, and brace yourself because you probably will get some emails as a result of our conversation here today as well. But anybody that can, help us connect people to more great people, that's what this community is really all about. So
yeah,
great.
Ian, do you have any last bits?
Yeah, I just wanted to remind people, you can check out the Obesity Canada website. There is a section there for these connected conversations. So if you look up connected conversations on the website, you'll find the recordings of all of these. I should have this one up probably tomorrow. So it'll be, you'll be able to watch it tomorrow. There's a newsletter mailing list that you can join. You can join our OC Connect community if you go to occonnect.ca. That is our private peer support community. So you can join that. And we have lots of opportunities to engage with us in conferences and events and things like this that are always happening. So just make sure you're following along, and we look forward to connecting with you again.
Amazing. Thank you so much, Dr. Chowdhury. I hope you have a great rest of today. And who knows, we may invite you back for another conversation along the way. But to everyone else, please take care of yourselves, be kind to yourself and at least one other person. Remember to wash your hands, and be awesome. All right. Thanks, everybody.
Thank you, everyone.